Good afternoon, everyone. Thank you so much for joining this session of Unpacking Bedside Bioethics. My name is Jamie Connerman-Cease, and I am a clinical ethics assistant professor here at the Center for Bioethics at the University of Minnesota. We are excited to have you here. Unpacking Bedside Bioethics is a quarterly lecture series focused on a range of bioethics topics that impact clinical work. Today, our focus will be on the ethics of conscientious objection through the lens of pharmacy. We are so excited to have our speaker, Tim Stratton, here today. Before we begin, I want to share some more slides that give some resources and share our resources for the center with you all. If you are a part of the mHealth Fairview system, the Center for Bioethics offers ethics consultation for inpatient services. That's a 24/7 service, and you can contact us either on Vocera or the AMCOM pager. We have a couple of housekeeping notes before we begin. Firstly, if you have questions during today's webinar, please use the Q&A function to ask or follow up on those questions. The chat will be disabled, so if you have any technical questions, let our center staff know about those questions through the Q&A function. Also, please do not use the raise your hand function. We don't have the ability to respond to those kinds of questions. This session is going to be and is currently being recorded. You can access recorded webinars through our website, which will be sent out in the link following this webinar as well. We also have enabled captioning for this webinar. You can enable that captioning to view it on the bottom of your screen by clicking Show Captions. And there is an evaluation. We really take your feedback seriously for this series. There's 3 ways to access the evaluation. First, it could pop up in your screen. There's a post-event email, and it's linked in the presentation's detailed document, which is available in the chat. If you are a University of Minnesota Health Sciences student and you are seeking IPE credit, we have a discussion requirement, part of that credit seeking opportunity after this webinar. So please use the presentation details document to access that link and complete a reflection form. And also, if you are seeking continuing education units for this webinar, you can request a certificate of attendance and find that also linked in the presentation details document. Let's introduce our speaker. So Dr. Tim Stratton is professor in the Department of Pharmacy Practice and Pharmaceutical Sciences at the University of Minnesota Duluth campus. He is also the supervising pharmacist at the Hope Clinic, which is an interprofessional student-run free clinic in Duluth, Minnesota. We are thrilled that Dr. Stratton is able to discuss the topic of conscientious objection with us today. If you would like some more information on Dr. Stratton and his notable career, please check out the presentation details document in the chat. And now I will turn it over to Dr. Stratton.
Well, thanks so much, Jamie, and thank you to the center for inviting me to speak on a topic that's dear and near to my heart. And let me pull up the correct screen and get into the proper format. And there we should be good to go here. So we're going to talk today a little bit about conscientious objection, the pharmacist's right to refuse to fill specifically contraceptive prescriptions, but we'll discuss other prescriptions as well that pharmacists have been refusing in the past and again more recently. For those of you unfamiliar with Minnesota and specifically with Duluth, what you have there is a picture of Lake Superior, and Duluth is located right on the shores of Lake Superior. We have a lot of shipping traffic out here. Lake Superior is the 2nd largest lake in the world and actually is big enough that it gets tidal action based on the phase of the moon. So come up and visit Duluth sometime. You know, July is usually pretty safe. We don't have snow flying by that point. So I want to start off here with a land acknowledgement. And so wherever you are joining us from, there are undoubtedly indigenous people. So we gratefully acknowledge the native peoples on whose ancestral homelands we are now meeting, as well as the diverse and vibrant native communities who make their homes in these lands today. We further acknowledge that 52 American land-grant universities, including the University of Minnesota, continue to profit from lands stolen from native peoples. And because words are not enough, if you are so inclined, I invite you to take a picture of the QR code or visit the link at the bottom there for the American Indian College Fund. Conflicts of interest. I personally do not have any conflicts of interest to declare. I will use occasionally drug trade names in the presentation. Please do not construe those as being promoting or endorsing any particular product by myself, by the College of Pharmacy, nor by the regents of the University of Minnesota. A lot of times it's just easier to use the trade names than the chemical names for some of these products. So after attending the session, I'd like you to be able to explain how a prescription for contraceptive medication may create an ethical dilemma between the prescriber, the pharmacist, and the patient. I'd like you to summarize how emergency contraceptives work and explain what this has to do with ethics. And finally, I'd like you to be able to explain how a state's Pharmacy Practice Act and a pharmacist code of ethics may contribute to a values conflict for pharmacists. You don't have to memorize these learning objectives. You will be getting another review of these as the presentation moves on. So, pharmacist conscience clauses. What these conscience clauses do is afford the pharmacist a right to refuse to perform certain activities that run counter to the pharmacist's religious beliefs or personal values. There's a couple of subcategories of these conscience clauses. There's the right to refuse to fill a prescription, for example, but includes patient protections. And in this instance, it means the pharmacist is obligated to try to help the patient find an alternative. The other subcategory are conscience clauses that do not include patient protections, which means not only can the pharmacist refuse to fill a patient's prescription, they are under no obligation whatsoever to help a patient find an alternative. So pharmacists have invoked conscience clauses over the years to justify, obviously for today's topic, refusing to fill contraceptive prescriptions. They have invoked conscience clause to refuse to sell, dispense, or even carry non-prescription or prescription emergency contraceptive products. They have used them to refuse to dispense abortifacients such as mifepristone, even if it's following a miscarriage or a physician-determined non-viable fetus. And so that's a whole nother line of discussion for a different time. And most recently, we've had pharmacists refusing to provide gender-affirming hormones. So we see these pharmacist conscience clauses playing a number of different roles. And I didn't even throw in the idea about participating in drug executions or helping with medical aided death. So those are other areas where pharmacist conscience clauses can be invoked. So here's just some wording examples from some of the states in the U.S. So Arizona, again, the pharmacist is not required to facilitate or participate in the provision of abortion medication, emergency contraception, which is specifically in the statutory language, or into anything that's intended to inhibit or prevent implantation of a fertilized ovum. This is going to play more of a role as we get into how these drugs work. So keep that in mind. The objection must be stated in writing and the prescription returned to the patient. So there's somewhat of a patient protection by Arizona and that the pharmacist just can't say, oh, you've given me the prescription, it's mine, and so you're on your own because I'm not going to fill it. South Dakota, no pharmacist may be required to dispense medication if there's reason to believe the medication would be used to cause an abortion, destroy an unborn child, and here in South Dakota, they do specifically mention causing the death of any person by assisted suicide or euthanasia. And then Florida and Montana, just this past summer and fall, have introduced into their statutory language that any provider may refuse to provide any healthcare service on the basis of their religious, ethical, or moral beliefs. And so this is the statement in Florida that some pharmacists have been using to deny the provision of gender-affirming hormones. So a map of the states, one of the questions that were sent in by a registrant was like, well, how many states have these conscience clauses? And so just to walk you through the map quickly, the states in red, and I went and used the stoplight kind of coloration here. It's not that red states are red states politically. That's not the intent here. But red light, so where the pharmacist can just completely refuse to fill a prescription and they don't have to help the patient find an alternative. Those are the states in red. Then we have states in yellow where the pharmacist may refuse, but statutory language prohibits the pharmacist from obstructing the patient's efforts to find an alternative care elsewhere. And in those cases, most of the time, the pharmacist in charge is obligated to help the patient find an alternative. The green states are the states where, by law, essentially the pharmacist has to fill any legitimate prescription. And that's got its own set of concerns. And we'll get into those a little bit later here. Then we have these hatch-marked states. And those are ones where the pharmacist maybe can refuse to fill a contraceptive prescription or emergency contraception. Some states specifically mention emergency contraception. Others just mention contraception in general. And yet other states, such as Texas, basically says the pharmacist has a right to refuse any prescription they don't want to fill. So different variations. These kind of dark teal states don't tend to address specifically in statutory language. There is one exception that'll come up here that I'm aware of, and we'll get to that here in a moment. So pharmacist professional associations have also gotten involved in this conversation because pharmacists' conscience clauses and right to honor their own religious or personal beliefs have been a topic for a long time. And I would argue that this has probably emerged as a topic since oral contraceptives were first introduced in the late 50s or early 1960s. So the American Pharmacists Association, APHA, came out with a statement back in 1998, and you can see that's been reviewed, updated again in 2004 and reviewed again in 2015, that the organization recognizes the individual pharmacist's right to exercise conscientious refusal and supports the establishment of systems that ensure patients' access to legally prescribed therapy without compromising the pharmacist's right of conscientious refusal. I would point out to you that in this statement, pharmacists' rights are at the forefront and the last thing that's discussed. And somehow sandwiched in between is the patient. If we contrast that with the American Society of Health Systems Pharmacists, so health systems are hospitals or health systems that include hospitals and clinics. Fairview would be a good example of that. Essentia, Mayo, they all have hospitals and clinics. So those are health systems. So ASHP's policy statement which was reviewed in 2015 most recently, they put the patient's right to obtain the prescription at the forefront, and then put the pharmacist's right to their conscience and their beliefs as kind of a secondary consideration. So two kind of different perspectives from two different organizations, two different pharmacy organizations. The American Pharmacists Association is kind of the umbrella organization that tries to represent the interests of all pharmacists, regardless of practice site or venue. The American Society of Health System Pharmacists really is more involved with pharmacists who practice in health systems. So the American College of Gynecology in 2019 came out with their statement about limits on conscientious refusal. And I'm not going to focus on the ethics concepts so much. I'm going to let you look at those yourselves. But the potential impact of provider refusal on the patient. So one is that a healthcare provider really is not supposed to be imposing their beliefs on a patient who maybe doesn't subscribe to those beliefs. So that's a concern. Some healthcare providers have been known to withhold scientifically accurate information or actually spread misinformation. And we saw some of this, unfortunately, during the COVID episode that we are still emerging from. If the potential refusal harms a patient's sense of well-being, then ACOG frowns on that. When a health professional ignores the scientific integrity of the facts that refute the objecting healthcare professional's claims, that is concerning. And we'll talk about that a little bit more as well when we talk about how these drugs function. Finally, if a provider's refusal discriminates against a patient, particularly in economically or geographically resource-poor areas. So this is a huge concern in rural areas, for example, which may have one provider or one pharmacy. And if that provider or that pharmacy refuses to fill a prescription for emergency contraception, that puts the patient in a really a great deal of inconvenience at best. And we'll talk about that coming up. So I just shared the American College of Gynecology's statement that came out in 2019. Just last year, several professional organizations, the American Medical Association, the American Pharmacists Association, the Hospital Pharmacists, and the National Community Pharmacists Association, which are essentially the primarily the owners of independent pharmacies in the U.S. And they issued this joint statement expressing concern about state laws that are limiting patients' access to medically necessary medications, impeding physicians and pharmacists from using their professional judgment. The statement also calls on state policymakers to ensure that patient care is not disrupted and that physicians and pharmacists shall be free to continue to practice medicine and pharmacy without fear of professional sanction or liability. So this was issued a little more than a year ago, last September. What prompted this statement? Keep an eye on this date, red letter date, because here's another red letter date. About 5 days later, legislators in the U.S. Congress on the Republican side in the House of Representatives introduced the Pharmacist Conscience Protection Act. And this act would have protected pharmacists to refuse to sell or fill prescriptions for drugs that cause abortion. The act aimed to reverse the White House guidance based on the Department of Health and Human Services opinion that denying to offer reproductive health products was an illegal form of sex discrimination. That will come back into play in a case we're going to look at. The statement called for the government to not discriminate against a health provider who does not or declines to store or fill a prescription or make a referral that causes an abortion, or that the specified health provider in good faith, whether based on science or not, but in the belief of the health provider, they believe it may be used to cause an abortion. This legislation did not get very far in Congress. So now we get to what I consider to be the fun part of the conversation, and that's the cases. So in the interest of full disclosure, these are real cases. Participants and the locations, I generally disguise. I love using cases in my courses to respect the privacy of the parties involved. I usually disguise the names, certainly, or the locations or the venues of where these cases occurred. But I'm not going to do that in this situation because the cases that we're going to discuss right now are matters of public record. So it's out there. And if you can Google this right now, you can fact check me. If you disagree with my interpretation, put that in the Q&A. We could talk about it. But these are the real deal. So this first case occurred in Wisconsin, which is a neighboring state to Minnesota. And the pharmacist involved was a contract pharmacist. And I'll abbreviate pharmacist as RPH, which is registered pharmacist. I am a registered pharmacist in like 4 different states. So this pharmacist was working for a contract pharmacist service outfit. It's called RPH on the Go. And in July, and you can tell this was a few years ago now, but in July, this particular pharmacist was starting a temporary position with Kmart, which is a large box store chain in the U.S. and has a lot of pharmacies in their stores. And so Kmart pharmacies in Menominee and Rhinelander, Wisconsin, which are rural or semi-rural communities, this particular pharmacist wrote RPH on the Go. So he wrote the service after he'd started the position, stating that he had a conscientious objection to participating in the work of contraception. So no birth control pills. He notified RPH on the Go, but he neglected to notify the pharmacies where he was assigned. And he went to state in his letter that participate in the work of contraception includes assisting in, recommending, making referrals for, or dispensing drugs for otherwise aid. So wanted nothing to do with anything that would interfere with the procreative process. So this pharmacist wanted to be excused from selling or counseling about drugs, did not want to be selling condoms, any kind of spermicidal creams. Those are things that are available without a prescription. Just go pick it up at the pharmacy counter or these days, probably at your favorite big box store. So this pharmacist wanted nothing to do with anything that would render intercourse to be sterile. He also did not want to participate in any procedure that prevented the implantation of a fertilized human ovum, including emergency contraceptive drugs. We will get to this again when we talk about how these drugs work or they don't work. He also listed 5 other procedures that he did not want to get involved with that really were irrelevant to community pharmacy practice. So, things like withholding and withdrawing nutrition or hydration, or participating in euthanasia. So this pharmacist was at his first Kmart. Now he was being placed at a second Kmart. And this time, RPH on the Go, the service notified the Kmart district manager that the pharmacist did not want to dispense contraceptives. The pharmacist informed the pharmacy manager at that site that he would not fill contraceptive prescriptions, but he did not indicate that he would not transfer a patient's prescription to another pharmacy. The way that system works is if a patient comes to a pharmacy and wants their prescription transferred, that second pharmacist will call the first pharmacy up and get information they need to go ahead and fill the prescription. And this applies to if a patient has a prescription with refills on it, those refills can get transferred. So keep that in mind. The pharmacy manager at this Kmart arranged to fill contraceptive prescriptions when the pharmacist was going to be on shift. So the accommodation was that a pharmacy technician would prepare the label. The pharmacy manager would be called into work to fill and dispense the medication. So one Saturday, this pharmacist was the only pharmacist on duty, which also made him the pharmacist in charge. And a patient presented requesting a refill on her oral contraceptive or her OCs, for which she had active refills at that pharmacy. The patient's next cycle of oral contraceptives was scheduled to start the next day. So this is a Saturday. Patient was going to start her next cycle on a Sunday, the next day. The pharmacist asked if the patient was using the oral contraceptive for contraception. OCs are used for other things as well, like regulating menstrual cycles and controlling acne. So OC, and trust me as a pharmacist who started counseling the patient, and it's like, well, that's not what I'm using the drug for. We had always asked the patient what they're using the medication for. It's not trying to be, we're not prying. It really helps us to tailor our counseling comments to the use that the patient has in mind for the drug. So the patient responded yes. And at that point, the pharmacist stated he would not refill the prescription due to his conscientious objection, and he asked the patient no further questions, such as, when are you supposed to start this next? So the patient asked the pharmacist where she could go to get her prescription filled. And the pharmacist responded, I'm not going to tell you, because he did not want to participate in the patient receiving contraceptives. So this pharmacist is at a Kmart. The patient went to a Walmart, different big box chain, and asked the pharmacist there to call the first pharmacy up and get those prescription refills transferred. The first pharmacist, refused to provide that information, as to do so would induce another to commit a sinful act. So the patient went home, called the first box store's assistant manager, the Kmart, and that assistant manager, who's a non-pharmacist, noted that the store had been having problems all day because women couldn't get their oral contraceptives filled or refilled during that while this pharmacist was working there. So on Sunday, Kmart is still open. The patient had two police officers accompany her to Kmart to get her medication refilled. Police officers got there and basically said there was nothing we could do about this. So 2 days later, the patient finally got a refill from another pharmacist at the Kmart, so the first store, but was counseled at that point because she had missed 2 days. She was counseled to use an alternate form of contraception for the entire cycle, for that entire next month, because she had started the refill late. She should use something else, like a condom. So this case ended up on the desk of the Wisconsin Board of Pharmacy. And the Wisconsin Board of Pharmacy found that the pharmacist had engaged in a practice which substantially departed from the usual standard of care, constituted a danger to the health, welfare, or safety of a patient. Essentially, you're guilty of unprofessional conduct. The Board of Pharmacy issued a reprimand and required the pharmacist to notify any pharmacy in writing at least 5 days before that pharmacist started a position at that pharmacy, which duties they would decline to perform. The board also required the pharmacist to provide the pharmacy with a copy of this board decision saying that you've been sanctioned, And the Board of Pharmacy required the pharmacist to take a minimum of 6 hours of pharmacy CE continuing education in ethics. So what are the ethics principles involved in this case? It should be pretty obvious. The first one is patient autonomy. That prescription is the patient's, and they can ask it to be transferred at any time. If you are a deontologist, such as Kant, and Kant talks a lot about duty. So the pharmacist had and was observing a duty to his beliefs. But I would ask, to whom does that pharmacist owe the greatest duty? Is it to the pharmacist's beliefs, or is it to the patient's needs, the patients that are right in front of you now? For the utilitarians in the group, Mill would talk about at what point does self-regard, so the pharmacist's regard for his beliefs, become others' regard. So looking at a different couple of philosophers, questions are raised ethically, let alone legally, but ethically. So when we look at the pharmacist code of ethics, the pharmacist also violated at least 3 tenets of the pharmacist code of ethics. One is to respect the covenantal relationship between the patient and the pharmacist. Basically, the pharmacist is promising the patient, I will help you get the care that you need. 2, the pharmacist promotes the good of every patient in a caring, compassionate, and confidential manner. Probably did not happen in this particular case. And finally, the pharmacist respects the autonomy and dignity of each patient. Now, this pharmacist code of ethics is a joint effort between APHA, the hospital pharmacists, several other pharmacy groups, the American Association of Colleges of Pharmacy, so the schools around the country. That's where this code of ethics emerged from. It's a group effort among the pharmacy profession. Okay, so we are ready for the first poll question. So in this poll question, I'm taking you back to the first learning objective, and I'd like you to think about how a prescription for contraceptive meds may create an ethical dilemma between a prescriber, a pharmacist, and a patient. And we'll give everybody a few moments here to and we'll give everybody about another 10 seconds here. Okay, so Jamie, do you end the poll or do I end the poll? Share results.
Results.
So everybody able to see the results?
Yep, thanks, Tim.
Okay, so I would agree. The vast majority of you indicated that the pharmacist's personal beliefs can conflict with the patient's autonomy. All right, now let's close that. Now we'll move on to the next case. So the next case happened here in Minnesota, just about an hour away from Duluth. And it was one of those winters where we get blinding snowstorms occasionally in this part of the country, where truly you can barely see the front of your car hood, let alone the vehicle ahead of you. So that's a blizzard. Lots of snow, lots of wind, almost no visibility. So on this particular day, a snowstorm was brewing near tiny McGregor, Minnesota. That is not the smallest town in the state. But it's located about an hour from Duluth or about 2 hours up from the Twin Cities. And there's a whole lot of small towns in between those two. So this particular patient called the physician after she and her partner had experienced a condom mishap, and it created a need for emergency contraceptive. Now, this particular patient and her husband or partner already have they are foster parents to 4 children and have one of their own as well. So they really did not feel they could afford another child at this point. So the patient called the physician up in January as soon as her usual birth control failed. The physician's office called in a prescription for a product called Ella. It's a morning after pill, and it was called to the only pharmacy in McGregor. Not surprising, a town of 367 has one pharmacy. So the patient called the McGregor Thrifty White. Again, I'm not disguising drugstore names because they're part of this public record. So the patient called the Thrifty White to ensure that the prescription had been received and that medication was available. Because again, we got a storm brewing. She doesn't want to go out if there's no reason to do so. If the pharmacy didn't have the medication, that might be for naught. So let's stop for just a moment here and let's talk about how emergency contraception meds work or don't work. So the case we're talking about right now involves a product called Ella, which is ulipristal. And the way that Ella works is it blocks progesterone. It needs to be used within 5 days of unprotected intercourse. The way that the medication works is it delays or stops release of an egg from the ovary. There's a possibility that Ella will change the lining of the uterus as well, the consistency of the lining of the uterus. But that's a secondary mode of action. Primarily, it delays or stops release of an egg. It's prescription only and is somewhat little bit more effective than Plan B. So if we go over to Plan B, this product is available non-prescription. And when the product first came out, some more conservative chain stores said that we just won't stock it. Well, that lasted for about 2 months, I'm going to say, until the market was so big that even those big box stores with their conservative leadership decided they had to make that product available. So whereas Ella can be used 5 days out of, or within 5 days of unprotected intercourse, Plan B really is effective within 3 days. So the clock is ticking. Plan B also delays or stops release of the egg from the ovary. So a very similar mechanism of action to Ella. We already mentioned it's over the counter. It's available without a prescription. If used within 24 hours, Plan B is about 85 to 90% effective. That effectiveness starts to drop off in subsequent days. So keep in mind how these products work. Oh, and it's time for our next poll question. Again, how does emergency contraceptives work? And explain what this has to do with ethics. And we still got responses coming in. Thank you for your participation. This is excellent. We'll give everybody another 10 seconds here. And I think we're good to share the results. And so, yes, the correct answer is B. A, no, not 7 days. It's 3 to 5. So that's really important. Timing is everything there. And again, the way that these products primarily work is it prohibits an ovum from being released in the first place. So it's not that the egg gets released and then the fertilization is blocked somehow. It's that the egg doesn't ever get released. And then contraceptives causing a miscarriage to occur. That's actually what mifepristone is used for. And this is if either there's spontaneous miscarriage where there's still tissue remaining, or if the fetus has been determined to be non-viable. And then mifepristone can be used to induce a miscarriage at that point. Okay, so we're going to close that. And okay, so we're back to the case. So we've talked about how these drugs work or don't work. Now let's whatever happened with the case. All right, so when we last visited this patient, she had just called the pharmacy up, make sure they had the drug in stock. Less than an hour later, the pharmacist who was on duty that day at that particular pharmacy called back and told the patient that he would not fill the prescription because he did not feel comfortable and it goes against what the pharmacist believes. So the pharmacist informed the patient that there will be a different pharmacist working at that drugstore the next day who might be willing to fill the prescription, but maybe not. And not only that, the pharmacist who was on the phone could not guarantee the second pharmacist would even be able to get into work. So after that, we've got that already. So the patient asked about other pharmacies. The pharmacist told the patient not to try the Shopko, different pharmacy, in the next town over, because the pharmacy employees there would also probably refuse her request. We have no idea what that was based on. And so the patient next called a CVS pharmacy that was 20 miles away and talked to a female pharmacist there who told her that the pharmacy did not have Ella in stock and unfortunately would not be able to get it from the wholesaler in time for the patient to use the pill. And remember, Ella, we've got a 5-day window where that drug can be used. So it generally doesn't take a wholesaler. If you order it that morning, you can oftentimes have it that afternoon or certainly by the next day. So failing that call, the pharmacist put the patient on hold and then called a Walgreens pharmacy in Brainerd, which is almost an hour away from McGregor, and then got back on the phone with the patient and said, you know, I talked to Walgreens and they don't have it either. So just to give you some idea as to what we're talking about here in distances, we've got Duluth here, McGregor, which is where this saga is unfolding. Aitken is 20 miles away. And then Brainerd, which is where the Walgreens was 60 miles away. This is all 2-lane highway. It's posted for 55. And we've got a blizzard on the way. So the patient did not take the CVS pharmacist's word and called Walgreens herself. The Walgreens pharmacist said, yeah, the CVS pharmacist called a little bit before. And yeah, we do have the product. Where we can get it, we can fill it for you the following day. So that's Sunday. So that Sunday, the patient strapped her young son into the car seat and drove 60 miles away to Walgreens in Brainerd. The snow started falling, the temps started dropping to single digits. So for those of you who are where centigrade temperatures are the norm, the temperature was dropping to minus 15C to minus 18C. And for those of you who are familiar with Fahrenheit, man, it was getting down to minus 5 to 0. So we're driving our way to Brainerd. Snow started falling. Here's the whiteout conditions I talked about. Usually the trip between McGregor and Brainerd is 2 hours round trip. This time it took 6 hours or 3 hours, I'm sorry, round trip. And if you've ever driven in a blizzard, you know how much fun that is not. So ultimately, the patient received the prescription from Walgreens, made it home safely after driving more than 100 miles or 160 kilometers, I think, through a blizzard. She did not become pregnant. So if we look at Minnesota pharmacy regs, and these date back to 1999, those pharmacy regulations stipulate that pharmacists can decline to fill a prescription for an emergency contraception, but they must provide an alternative way for the patient to fill their prescription. It's the responsibility of the pharmacist in charge. And again, the pharmacist in McGregor was the only pharmacist there. That, by definition, made him the pharmacist in charge. And so he is obligated to make arrangements with a nearby pharmacy to fill the prescriptions so that appropriate information can be communicated immediately to patients. So the patient sued the pharmacist involved, sued CVS for lying, sued Thrifty White in the county court. Again, this is a small, more conservative county in Minnesota, and sued under the Minnesota Human Rights Act, arguing that the pharmacist's actions constituted discrimination based on sex, denying the patient pregnancy-related health care. Again, this is the state constitution, not the or the Human Rights Act. I'm sorry, it's the Human Rights Act. It's not the state constitution. So the results of the lawsuit, and these results just came out like, I'm going to say, a year ago. So all this happened in 2019. It took 3 years for the lawsuit to work its way through. Jurors deliberated for 9 hours. They ruled that the pharmacist did not discriminate against the patient. They further ruled that the pharmacist was liable for emotional damages and awarded the patient $25,000 for pain and suffering. The patient was represented by a group called Gender and Justice out of the Minneapolis, St. Paul area. And I keep checking to see, they were noting that they were going to appeal the case or the judgment, but I haven't been able to find that they've gone any further than this particular decision. All right, so what ethics principles do we have at play here? Again, patient autonomy. Kant with duty, we've talked about that. Mill with self-regard versus others' regard. This time, the same 3 tenets of the pharmacist code of ethics were violated by the pharmacist, in my humble opinion. But also a 4th one, the pharmacist acts with honesty and integrity in professional relationships and avoids actions that compromise the patient's best interest. Didn't happen in this case, by a couple of pharmacists, as far as I can tell. So our final poll question, and give everybody a few seconds here to respond to that. I apologize for being so wordy in my multiple guess questions. Okay, why don't we go ahead and share the results here. And indeed, the answer is D. And I didn't talk too much about a governor's executive order, choice B, but indeed, soon after the Nosen case happened in Wisconsin, the governor of Illinois, a neighboring state, went ahead and by executive order, ordered pharmacists to fill any legitimate prescription. There's issues there. There may be times when medication may be not appropriate for the patient's condition. Maybe the patient can't afford the prescription, and so the pharmacist needs to intervene with the prescriber to see if they can come up with a different alternative. There may be times that patients are doctor shopping or pharmacy shopping with controlled substance prescriptions for opioids, for example. And in those cases, the pharmacist is within their right to decline filling that prescription. But the pharmacist also has an obligation at that point to try to help the patient get assistance for their addiction and to help that patient get into a treatment center somewhere. Okay, so to summarize the presentation today, contraceptive meds may result in a conflict of values. They could create an ethical dilemma between a prescriber, the pharmacist, and the patient. Emergency contraceptives do not result in abortion. And what I have here is the statement from the Food and Drug Administration, U.S. Food and Drug Administration, that is adamant on that point. And finally, state conscience clauses for healthcare professionals may conflict with the provider's professional code of ethics, where the state says, nah, you don't have to help a patient do anything. And the pharmacist code of ethics said, well, yeah, if you don't have to fill a prescription, but you're under obligation to help the patient find an alternative somewhere. And with that, I think, yes, we are up to discussion. So I will stop sharing.
Fantastic. Thank you so much, Dr. Stratton, for your presentation. We have about 8 minutes for questions, and I want to get at some of these questions asked by our participants. The first thing that I was really struck by, and that I think we can help understand that applies to all healthcare providers, is this covenantal relationship in pharmacy between the provider and the patient. And I want to think a little bit more about that. One of our questions from our audience asks, is a pharmacist's conscientious objection different from an Amazon delivery driver or a mail carrier who objects to whatever's being delivered to a customer? So how is pharmacy and healthcare in general different from regular consumer interactions?
Yeah, that's a really good question. And in the area or the case of a Amazon driver or a mail carrier, a letter carrier, they're not supposed to know what they're delivering. And so that's a big difference. In this instance, the pharmacist knows darn well what's being dispensed, probably is a good idea as to why. And again, I will tell you, I've worked with physicians before who refuse to write contraceptive prescriptions for unmarried women. It's like, you were married, we'll write it for you, you got divorced, you don't need that anymore. So it's a very different relationship between a provider and a patient.
That segues really well into the next comment, which I'll draw out into a question, which is sort of about the reasons why people are seeking prescriptions. And in the counseling encounter between a pharmacist and a patient, there's often an explanation of the reasons why, right? Like you shared in that case, a particular woman had 5 kids, she could not afford to have another child. And so how should those reasons play into conscientious refusals, and what role do reasons have? Like, is there ever a time when for a same prescription, like you said, somebody could justify or not justify withholding a particular prescription?
Well, let's set the controlled substance issue aside for a moment, because that's a different kind of a conversation. And what we teach our students to do and the way I learned this is from the Indian Health Service, where you ask 3 prime questions. And the first question is, what are you using the medication for? Again, it's not to pry, it's to find out what the patient knows about their medication. And then the next question is, what did the prescriber tell you about this medication, or what to expect from the medication? And then the third question is, what else did the prescriber tell you about this medication, which may be different ways to store it and that sort of thing. There are times when I've worked with patients who I've asked, so what are you using the medication for? And I was told in no uncertain terms, it is none of your business. And it's like, okay. And I explain why I'm asking. And then if they're insistent, I can tell them that, well, this medication is usually used, if used for this, these are the concerns. If you're using for that, then these are the concerns. Generally, the side effects are going to be the same regardless, which is a big thing we always want to try to caution the patients about. So I don't know if I've adequately answered that question, but
yeah, I want to think through a little bit more about if as an individual healthcare provider, when you hear about a patient's reasons, are you able to incorporate those reasons to justify something like a refusal, or should you simply just take their request, as like, I'm requesting this particular prescription and that's all you need to know, for me, my refusal or not?
Yeah, no, that's an excellent question, and it actually goes a little bit different direction. When can a provider, in this case a physician, deny a patient's request for particular treatment?
Right.
And one of the cases are, if it's clearly futile, then the provider can decline. If the treatment might harm others, then they decline it. So if a patient wants a live measles vaccine, for example, but they have a person living at the house with them who is immunocompromised, then no live vaccine for you. So we've got futility, harm. If it would, harm to others, and I'm blanking on the last couple of things, but there are instances where it is ethically permissible for a provider to decline.
The thinking more about refusals, it seems to me like there's the big ethical debate in conscientious objection is around refer or not to refer. And I'd like to hear your perspective on taking in light the importance of the covenant of a pharmacist and patient. Where would you recommend as the most ethically appropriate kind of answer to that debate?
Well, this is where my personal biases will come to the fore, because personally, I believe that the pharmacist is obligated to help the patient find an alternative that's acceptable. And when we talk about acceptable, we're talking not about 60 miles away in a blizzard. It's going to be easier sometimes in an urban area to refer the patient to another source. Other ways around this, some clinics will have their own supply of some of these medications. And so if the pharmacy doesn't want to get involved, we can refer the patient back to the clinic. But that only works if the clinic happens to be open. So that would be another alternative. I tell some of my students that if you're really, really opposed to this, there are other areas of practice or pharmacy that you can practice in that you will never involve contraceptives, geriatrics, drug information, those types of things. And I'm watching the time, and it looks like we're very close.
1 minute. I want to ask one more question from the audience. This attendee asks, as long as we want to accommodate some but not all conscientious objection, we have to decide which beliefs are reasonable enough to justify that accommodation. So how do we determine which beliefs are reasonable?
Oh.
Maybe you can just give a framework or share how we
30 seconds? Okay. No, that's a tough question. That's where it's the person has to look deep inside of them, and they're going to decide what's reasonable and not. And then there may be others who disagree with them, such as a board of pharmacy. So with actions, there will be consequences. Sometimes it will be consequences in the afterlife, and other times it may be consequences in the here and now. So
I think that's a great answer to explore that, right? And then as a community, right, we can sort of judge out on the community level, right, through
yes,
legislative action, what kinds of
absolutely.
things we consider reasonable. So thank you so much, Dr. Stratton. There are directions if you are interested in, if you are a University of Minnesota Health Sciences student attending our IPE session, please follow the directions on the screen. I also want to plug some upcoming events that we have at the University of Minnesota Center for Bioethics. This Friday we have or coming up in February, I should say, we have a ethics grand round on health equity and climate change. Our next Unpacking Bedside Bioethics session will be in February on envisioning adolescents as decision makers in healthcare. And next unpacking after that will be by yours truly on the distinction between withdrawing and withholding. So thank you so much, Dr. Stratton, for this presentation. It's been fascinating, and we really appreciate you sharing your expertise with us today. Thank you, everyone,
Thank you all.
for joining.